early trials of immunotherapy, what we saw was very interesting. The chance of response, unfortunately, was kind of low. Most patients did not get a response, but those that did get a response found that response to be very durable. And what we saw was responses that could last. Our 2-year survival rate was about 26%. With chemotherapy alone, we'd expect that number to be pretty close to 0. With immunotherapy, we saw that as high as 1 out of 4 patients were surviving many years afterwards. This was new to us. This was very exciting. We then did studies looking at immunotherapy in people that had multiple lines of treatment. Nivolumab, which is a PD-1 inhibitor, and pembrolizumab, another PD-1 inhibitor, were studied in patients that had prior lines of chemotherapy. And when we gave immunotherapy as treatment number 3, as third-line treatment, what we saw was the chance of response was low, 12 to 20%. And so a low chance of response, but they were durable. Here, the average duration of response, about 1.5 years. And that was enough to grant accelerated approval by the FDA. Accelerated approval is sort of an early approval, but requires confirmation in larger randomized studies. And unfortunately, those studies for these drugs were negative. Immunotherapy is still active, but it did not confirm enough benefit to maintain its approval. And so the use of nivolumab and pembrolizumab, those are no longer approved by the FDA. We think the best way to use immunotherapy is as part of the frontline treatment. And so the first-line study looking at immunotherapy was, fortunately, positive. IMpower 133 was a global phase 3 study looking at the immunotherapy agent atezolizumab, a PD-L1 inhibitor given with chemotherapy. In this large study, everyone received chemotherapy as their first treatment, and patients were randomized to get concurrent immunotherapy with atezolizumab or placebo. After 4 cycles of chemotherapy with immunotherapy, they then received immunotherapy as maintenance treatment indefinitely, or until intolerance or progression versus placebo. Adding immunotherapy to the chemotherapy and continuing the immunotherapy afterwards improved survival. What we saw was an improvement in the median survival from 10.3 to 12.3 months. What that means is about a 25% reduction in the risk of death. If we look at the numbers, we can see that at 18 months, the chance of being alive was 34% with the immunotherapy regimen versus 21% with chemotherapy alone. I appreciate this is a modest benefit, but this is really the first positive trial we've had in several decades. And that led to the FDA approval in March of 2019, European approval in September 2019, and its current listing as a Category 1 preferred option. A first survival advantage in nearly 4 decades, really establishing chemoimmunotherapy as our current preferred standard of care and best practice. There have since been several other trials showing the same thing. The Caspian study, another phase 3 randomized study, showed that when we add the PD-L1 inhibitor durvalumab to chemotherapy, we see a very similar outcome, a modest but significant improvement in survival. Here, the improvement from 10.5 to 12.9 months. Again, about a 25% reduction in the risk of death. There have actually been several studies now, some overseas in other countries, showing that when we add immunotherapy to chemotherapy in the frontline setting as treatment number 1, we improve survival. A modest improvement in survival, but an improvement nonetheless. It is best to use immunotherapy, though, early in practice. A study looking at second-line nivolumab, meaning after chemotherapy, when the cancer came back, then giving immunotherapy versus standard chemotherapy, did not show that immunotherapy was better than chemotherapy. And using it as a maintenance treatment earlier on also did not improve survival. Now, our preferred treatment is in the frontline setting. Now, if cancers do come back, if the small cell lung cancer unfortunately does relapse, what are the options? Well, our historic treatment has again been chemotherapy. Topotecan was approved based on a phase 3 trial. The chance of response with topotecan, about 24%. Survival, about 25 weeks. And so outcomes that certainly have room for improvement. Those are our current standards. In Japan, the agent amrubicin was approved, and in US studies fared fairly similarly to topotecan. But these chemotherapy drugs do have a lot of toxicity. Topotecan, though, certainly an approved and reasonable standard. It comes as an IV given for 5 consecutive days or as a pill.